Hello, 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 hello. Good afternoon, everybody. Thank you for making it. I am going to share my screen to begin. Can everyone see my screen all right? Yeah, thank you. Happy Wednesday, everybody, and thank you for making it to our first webinar series. You are welcome to TSU Baylor College of Medicine P20 Cured first webinar of its kind, and this first one is titled Social Determinants of Health and Cancer Disparity. Thank you to all our panelists, our participants, our facilitator, and everyone who's been able to join us in the noon hour to eat lunch with us and to learn more about determinants of health. Without much further ado, I'm going to go ahead and kick off this webinar series. So just some general announcements. Again, welcome and thank you for joining us. Please feel free to know that there is going to be a Q&A session at the end of this, at the end of the speaker session. And please go ahead and put those questions in when the time comes and you have a question to ask, and we'll try to get to it during this session. If we cannot, we'll make provisions to send you answers to those questions. So please feel free to post your questions in the Q&A box or to you, our online attendees. And then without much further ado, I am going to, I am going to be introducing our fabulous moderator, Dr. Deborah Murray. She is a leader in equity, mentoring, and research education, is a 2021 recipient of the Norton Rose Fulbright Faculty Excellence Award in Educational Leadership. She was awarded the All of Us Evidence with Genetics Research Program from the NIH All of Us Research Program. Dr. Murray is Director of Genetics, Genomics Education Programs in the Human Genomics Sequencing Center and an Associate Professor in the Molecular and Human Genetics Department and Co-Director of the Office of Community Engagement and Equity at Baylor College of Medicine. She provides faculty training opportunities and medical genetics training programs for M1, M2 students. She is a member of the Engagement, Communication, and Education team that provides community engagement research for the Intellectual and Developmental Disabilities Research Center, an Education Core Director of the NCI P20 BCM Texas Southern University Partnership Collaborative Union for Cancer Research, Education, and Disparities, also titled CURED. Without much further ado, Dr. Deborah Murray, and I'm going to help you advance your slides, Dr. Murray.
Thank you so much, Dr. Ogbo, for that introduction. Welcome, everyone. Good morning, good afternoon. We thank you for joining us at our first community engagement webinar series addressing cancer health disparities. We are able to bring you this series through funding from the NIH National Cancer Center. Next slide, please. This was the first grant that was funded in the United States in this cycle. Next slide. We will show you the team from Baylor College of Medicine and Texas Southern. There we go. So we have the faculty from Texas Southern on the left with Dr. Adjoli, and on the right, Dr. Rouse and her team from Baylor College of Medicine. They hold the distinction of being the only grant funded in this cycle. And the plan is to impact the community through this award by developing a collaborative alliance between Baylor College of Medicine and Texas Southern for cancer research, education, and community outreach. Also training and promoting a diverse biomedical research workforce and supporting a pipeline of collaborative, innovative cancer research pilot projects. Thank you. Please, next slide. We want to make sure that you give us feedback so that we can improve this series. You can scan the QR codes here, also in the chat periodically through the hour. You'll also get a chance to follow the survey and answer that for us. Thank you. Please, next slide. All right, so we will hear today from Dr. Hunter, and then we'll have a panel discussion, and we ask that you hold your questions until the end so that we can add those questions in and have a rich discussion of the topic. So Dr. Rodney Hunter is a board-certified oncology pharmacist who is a distinguished clinical associate professor at Texas Southern University's College of Pharmacy and Health Sciences. He also holds positions as clinical assistant professor at the University of Texas Health Science Center at Houston McGovern Medical School and clinical pharmacy specialist at UT Health Memorial Hermann Cancer Center. Dr. Hunter earned his Doctor of Pharmacy degree from Texas Southern University and completed a fellowship in oncology at the University of Texas MD Anderson Cancer Center. Dr. Hunter serves as the program director of the T.L. Burks Breast Cancer Outreach Center and is an advisory board member for the Texas Southern University Breast Cancer Screening and Prevention Center, funded by the Cancer Prevention and Research Institute of Texas. Additionally, he is the principal investigator of the Artificial Intelligence Machine Learning Consortium to Advance Health Equity and Research Diversity in Cancer at Texas Southern University, in collaboration with the University of Texas Medical Branch. So we will now hear Dr. Hunter give us a talk, and after that, we'll have the panel discussion. Thank you.
Thank you very much, Dr. Murray. I appreciate that introduction, and I'm very excited to be here today. Let me share my slides here. Okay, let's go ahead and roll. So as we dive into this social determinants of health and how it affects cancer health disparities, of course, we'll have a panel discussion later on, and we'll talk about some of my research that really focuses on this, as well as some of my collaborators and fellow panelists. But definitely wanted to establish what exactly are social determinants of health. I think we throw the words around a lot, and especially in the community, I think there's not a great understanding of how we actually got to this point where we start to study these social determinants of health. What are like the governing bodies? What are the places where we get a lot of the information to put our foundations down for trying to study this and really answer a lot of the questions that we have? So when we look at social determinants of health, we can break them into 5 major categories, and this is done by the Healthy People 2030 Consortium, which is also a government institution, an institution-funded program that looks at economic stability as one of the major pillars of social determinants of health, and how we establish and how these things affect patients, whether it be like employment, lack of employment, jobs that end up causing patients to have, insurance that won't cover fully the healthcare needs that they have, food insecurity. So, we talk a lot about patients not having, options as far as healthy foods are concerned. And later on down the line, those are things that can certainly affect patients' health. Housing instability. And I'll frequently probably refer to some of my clinical experience and where I've seen patients that are lost to follow up. And when we send messages and try to call them on their original contact information they've given, it's changed. And now we can't get a hold of them, and we can't get them in for the treatment that they so very much need. And in poverty, I think money is one of the driving forces, and is something that we definitely will try to analyze from a research perspective to try to answer those questions about how is patients' lack of money or instability in reference to finances affecting their health. Next one is actually educational access and quality. So there are several studies, and as we get towards the end of the presentation, I know I only have 20 minutes. This is a very big topic and one that I'm passionate about. But as patients receive more education, they tend to be healthier. These are actually multiple studies that have shown this. Enrollment in higher education has positive effects on the long-term health overall of patients. High school graduation, all of these things are things you could quantify graduating from high school and how it affects your actual health. And it has nothing to do with the type of medications that a patient takes. It has nothing to do with even the physician or healthcare professional that is taking care of the patient. Something as simple as high school graduation or higher education can directly affect health on average. It's just more about the language and the literacy of what's done when you do get to the office and you are being educated about your healthcare needs. So these are things that we want to study, that we want to provide additional support when needed to maybe move that line and make it closer to equal for all parties, regardless of race or ethnic background or even educational level obtained. Now going back into healthcare access and quality, this is another big perspective when you look at patients that are living in maybe rural areas where they don't have access to large healthcare systems. We get this a lot where we have patients that are traveling hundreds of miles to be seen in the Texas Medical Center because they're looking for a higher level of care, and they are mindful and they can identify with the fact that the level of care, maybe the area that has very small healthcare services or not well established, is something that can affect their health. So there are patients that will travel far distances to receive treatment, understanding that even if they are being treated in their respective areas, there may be access to more resources if you go to a larger healthcare system. Access to primary care. Your primary care physicians are a lot of times the first to catch things like cancer, for instance. They're going to be maybe that first person to come in contact with that patient that has an abnormal either screening mammogram, if we're talking about breast cancer, or has an elevated PSA. These are things that you could possibly pick up early on in the primary care. But if a patient does not have access to primary care in a way that they'll be able to get those regularly scheduled screenings of known cancers that we can pick up early and treat very well, then it'll affect their health ultimately. The health literacy is also something that's really what the foundation of this grant that we've obtained at Texas Southern University with Baylor College of Medicine. And while we're having programs like this, is to improve health literacy so patients themselves can understand better what we're trying to do as healthcare professionals and how we're trying to help them and what they need to know to be an advocate for themselves to receive the best level of care. So I won't steal the thunder of my counterparts, but when we talk about neighborhoods and the built environments that individuals live in, it goes to the point of talking about food. So if you live in an area where there's not a grocery store that's actually within walking distance, of course that can affect how often you eat fast food. And eating this fast food or eating this food that's unhealthy can directly affect, essentially your health. Whether it be from a cardiovascular perspective with your heart, it could be from a cancer perspective, because there's several studies that will suggest or even support the conclusion that obesity as well as poor diet can contribute to the incidence of cancer in general. So these are things that we as healthcare professionals, we're trying to identify these social determinants of health so that we can provide support early and often to maybe move the needle and impact primarily how patients are being treated. Now, going back to the neighborhood, so environmental conditions, certainly, that the environment can directly affect how patients' health reacts to things like incidence of cancer. Chemicals can increase the incidence of cancer. You have patients that have problems with breathing because of high levels of pollution. All of these environmental concerns and the quality of the places the patients live in, they all can contribute to the health either in a positive or a negative way. And then to finally kind of close the door on the neighborhood and the built environments, when you're talking about crime and violence, sometimes there's a hierarchy of what a patient is focused on. If they're focused on being safe as opposed to focusing on their health, that's certainly something that can affect them long term. So places where there is a lot more crime and violence, there's links to that being a negative effect on a patient's health, even outside of them getting the standard treatments, just in general. So this is one, and this moves into I have some data towards the end of the talk about this. But when you look at the social and community context of social determinants of health, there are several places where patients can maybe receive discrimination directly related to them receiving their health care. So maybe they're not treated the same. It's exactly the same way as the counterpart as their minority or white counterparts because of maybe false sense of assumptions on what the patient wants for their health or what they think patients can do. I've certainly come in contact with this in real time to where there's interjections that need to be made about an assumption that a patient maybe would not go through a treatment because they had to come multiple days a week and they were not going to come. And that's something that the patient needs to be the one to make that type of decision. That can't be something that we as healthcare professionals make. We don't want to assume that because a patient looks a certain way or has a certain color that they are not going to be able to tolerate a treatment or not going to be able to adhere to the schedule of a said treatment that's planned for them. So these are the type of things you see when you talk about discrimination and social determinants of health. What we can do as health professionals to negate this and be mindful of it and identify it early and often. Incarceration. I have some studies that I'll present that actually talk about how poor a patient's health is if they are incarcerated. I mean, the numbers are going to be alarming when we really get to that portion when I'm talking to you about how poor patients do if they have cancer and they are incarcerated. And social cohesion is another thing that's there about, patients having disproportionate health outcomes directly related to a social group specifically. So this brings us to the last kind of topic or concept when we're talking about the social and community context of social determinants of health. A lot of these things can possibly be addressed with voting, the voting at the polls. When you're looking at choosing your government officials and you're looking at why you want to vote left versus right and all of these types of things, something that could come into context or something that could come into play is looking at healthcare and what is the stance on healthcare? What is the position of the candidate on healthcare, especially when it relates to individuals that are disproportionately affected by certain types of healthcare concerns and healthcare problems. So this is a big part where I think maybe as a patient, you don't think about it as often, but certainly voting directly affects the lives of individuals all over the country, and not something that you see talked about as much, but certainly you watch debates and you watch different political outlets, you'll see that sometimes it's a hot topic on specific topics, but there's a host of different topics that never get touched. And this is our opportunity to bring those to the forefront for you as a patient. So you understand that you want to know the position of candidates on things like social determinants of health and the community outreach perspective to make sure that everybody is receiving the same level of care. And as we move into, we talked about the civic duty of individuals as far as voting is concerned. And let's talk about the continuum of care and disparities. There are so many places that we can touch here as far as like what exactly we want to do as healthcare professionals to move the needle and to even out the playing field. That you see drug development, which of course is the beginning. So when you think drug development, think clinical trials. Think what happens to patients who are in clinical trials and how do they benefit versus patients who are not in clinical trials and how do they benefit. Risk reduction, and risk reduction is really talking about understanding what patients are good candidates to receive treatments before they actually develop the cancer, but we already identified that they're at high risk for developing cancer. So those risk reduction strategies are disproportionately brought out to the minorities, and those are things that we want to address. That can ultimately move the needle when we think about how many patients are negatively being affected by a certain type of cancer, and those who maybe have better outcomes. Early detection, and I know it's not the focus of today, but Dr. Edgeworthy leads a huge program related to early detection of cancer. It's got a breast cancer component to it, and we hope to expand it in Texas Southern to be even larger than that. But the early detection and disparities is a very, very important aspect that needs to be addressed when we try to work on screening patients in general when they should be screened to catch the cancers as early as possible and ultimately as we catch the cancer earlier, we'll have better outcomes on the back end. And then treatment, and treatment goes to, and this actually, this graph about precision medicine is really related to treatment. We had a event actually just like a week or two ago related to prostate cancer, and there was a big portion of it that was focused on precision medicine. And it's the understanding that everybody's disease is not the same. Their ancestry affects the disease and how it works. The geography of where they're diagnosed affects the type of cancer they will have. There are so many different aspects of a patient that need to be analyzed before you give every single patient the same exact thing. So I think that's like a big thing that we as healthcare professionals want to address, and we as healthcare professionals are excited to study with the thought process that we will come to a conclusion. And it's survivorship, because once you get done with having cancer and once you are theoretically cured, there's a host of things that you typically need to do. And there's disparities in the level of survivorship and how patients will be followed after they have had cancer, received treatment, and are now being on surveillance where they're being watched to make sure nothing comes back. And in certain situations, survivorship involves taking medications on a daily basis that you would take by mouth, making sure the patients have compliance with that is a big part of survivorship. So just wanted to bring some numbers to you. This is specifically talking about cancer screening and disparities that you see. So as I referred to when you talk about early detection, patients who had their first mammogram, when you compare white women to black women were twice as likely to be diagnosed with breast cancer on their first mammogram. Why is that important? Because if you have a lower percentage of patients who are African American who are receiving a mammogram at the time that they're supposed to receive it, you can see how you can move quickly down to the bottom point where I'm talking about the comparison of disparities in the cancer deaths in white patients versus black patients between 1990 and 2020. There's a 33% in 1990 versus 11.3% in 2020. These are important numbers. It shows you that the needle is being moved, but the needle is moved by addressing early detection, addressing survivorship, addressing the treatment of patients and what they're being treated with, respective to the background from an ethnicity standpoint, minority perspective, all of those things. So when you look at Black and Hispanic patients who have triple negative breast cancer, you'll see that it's an 18% and 13% less likely, respectively, incidence of them receiving the guideline adherent treatment compared to white patients. What does that mean? That means that the best treatments that are out there for patients that we would expect you to get, patients don't always receive those treatments. And there's a host of different reasons why, but those are the questions we want to answer. Those are the studies that we want to do for patients. So the desegregation of cancer data, and I think this is a very important aspect, because you try to throw all patients into a barrel because they have similar skin colors. It is not the correct way to go about things, because their genome is totally different if they're from a totally different area of the world. You'll see these are just a few studies that show this, but it's the idea that if a patient is of Hispanic descent, that you would throw them all into one box, or if a patient is a non-Hispanic Black person, that you would throw them into one box. And you see from this study looking at non-Hispanic Black women who were born in Africa versus those who were born in the U.S. versus those who were born in Jamaica, and you see differences throughout. So you see that when you compare the patients that were born in Africa, the incidence of all cancers combined double in those born in the U.S. And then you see the patients that were born in Jamaica, they actually had a 21% lower incidence of the cancer compared to the African patients. So you're just looking at patients that look very similar if we pick them up in a lineup, but the genome is different. The demographic, the geography of where they were born is different. And that's where you can pinpoint some of those differences in outcomes and incidence of cancer in general. Looking at the second bullet, you're seeing Hispanic patients from South America and Central America compared to the patients who are Mexican, of Mexican origin. And then you see this 10% less likely incidence, but then you go to the Dominican patients and you see that there's an 18% more likely to develop aggressive forms of endometrial cancer. So you have this host of different patients where you would look at them and there's similarities in reference to how they look, but you see that there are differences as far as like them developing certain types of cancers. The medically unserved population, as we kind of round out to the end and we move to our panel discussion, it's looking at patients depending on their age. Adolescents and young adults, characterized as AYA. These patients have 31% lower 5-year overall survival rate within ALL, which is a form of leukemia, compared to the younger patients at age 0 to 14. So truly, outside of any ethnic or minority population, we're just purely talking about the patient's age and how it affects outcomes of different disease states. Looking at older patients who are above the age of 65 or 65 or older, living in rural areas, have a 78% more likely risk of dying within 1 year of a cancer diagnosis compared to those who live in urban areas. Finally, as I round off and we talk about those patients who are incarcerated, patients who are never incarcerated, and when you compare those to patients who are incarcerated, the cancer-related death at 5 years is 39% higher in those patients who are incarcerated. And even more alarming is those patients who have recently been released, they're 82% higher of a cancer-related death at 5 years compared to the patients who have never been incarcerated. So these are numbers that are staggering, and this is why we're doing a lot of the research that we're doing with the CURE study and across the medical center, across the continuum. And then finally, when we're looking at approaches to reduce cancer disparities, building community trust and partnerships is programs like this, where we're looking at the community and trying to educate the community, developing, tailor-made interventions for the population that we want to serve, implementing patient navigation to get patients to screening, improving the access to insurance coverage, as I talked to you about. Employment and financial limitations can directly affect patients' health, and then enhancing communication in general with the patient and the healthcare team. And with that, I'll give my acknowledgments to our P20 grant that I'm so proud to be a part of. Dr. Veronica Agiroli, my student, my colleague, my mentor at times, and also Dr. Rain Rouse. And with that, I'll hand it back over to the audio team. Thank you so much for your attention.
Okay, sorry about that. Thank you so much, Dr. Hunter. You laid it out really nicely and gave us the data so that we know what the actual real issues are and see the differences. So I want to introduce you to our panelists. First, Dr. Laura Solitaire is an esteemed academic and practitioner in urban planning and environmental policy. She is an associate professor of urban planning and environmental policy and the associate director of the Center of Excellence for Housing and Community Development Policy Research at Texas Southern University. Dr. Solitaire earned her PhD in urban planning and policy development from Rutgers University. Her research interests include land use policy, environmental planning, and public health. Dr. Solitaire has successfully led numerous grant-funded projects, securing over $10 million from federal agencies. Her work delves into the social determinants of health, exploring how urban planning and policy can influence health outcomes in underserved communities. She examines the impacts of environmental factors like access to green spaces, transportation equity, and housing stability on public health. Her research underscores the vital role of planning and promoting health equity, particularly those through health impact assessments and community-based research. Next slide, please. I want to introduce Dr. Abiduin Olayuami. Hopefully I'm saying that somewhere close to right. So he's a tenured associate professor of medicine in the section of epidemiology and population sciences at Baylor College of Medicine. He is a highly sought out, actively participant in research and program leadership teams at local, national, and international levels. As an environmental health epidemiologist, he brings extensive expertise in population health, environmental health, and data science. His research focuses on measuring neighborhood-level health determinants and exploring how these factors are linked to diseases and their risk factors. Dr. Olayemi employs spatial epidemiology and geographic information systems to emphasize the significance of neighborhood level stressors on health and well-being. So thank you both for joining us today. And we want to have you come into this discussion. And we ask that the audience will post their questions in the Q&A box for the online attendees, and we'll answer those as we go along. I'll start them off with a few, and we could stop sharing the slides. So first question to Dr. Solitaire: does non-medical drivers of health or social determinants of health impact bladder cancer incidence and outcomes?
Hi, good afternoon. Thank you for having me, and thank you everyone for being here. So I want to just share a little bit of my perspective as I answer these questions as somebody who is an urban planner, and going to Dr. Hunter's overview of the social determinants of health. As a planner, I focus a lot on those built environment determinants. However, we have to know that there is, that the social determinants overlap with the built determinants. So what determines, for instance, where somebody lives? Of course, we know that that's going to be income. What determines income? Well, education level. What determines education level? It may be related to race. And then, of course, going back to where they live is going to determine a number of things that Dr. Hunter was reviewing, including the likelihood of exposure to environmental pollutants, because facilities may be being located in their neighborhood, and or that their job may be more likely to be in such an industry. So coming back to the question, about how do these social determinants of health impact the bladder cancer incidence? Well, and some of my other colleagues know much more about the pathways of exposure, but we know that there are environmental exposures. We know exposures to certain, carcinogens and other things that may be air pollutants are going to be disproportionately impacting people, particularly people of color and lower income people, based strictly on just where they live. We know that the access to healthcare that, again, Dr. Hunter went over is going to be different in your neighborhood of, for instance, what does it take to get to a doctor? And I'm talking physically, like how do we drive or take a bus, and how many buses to the doctor? So all of these kind of different factors, and that we as planners are looking at of how do we, for instance, get better food, address food deserts that may be in a neighborhood. How do we address the transportation needs? Of course, what are the policies about affordable housing, and why is it so disproportionately, in the terms of here of in the least desirable environments, meaning, exposure to air pollution, et cetera. So, coming back to kind of the basic question is absolutely, yes, the social determinants of health can have, significant impacts on bladder cancer incidence and the outcomes.
Well, thank you so much, Dr. Oyeyemi, and I want you to say your last name so I can hear you say it. What are the measures of social determinants of health or non-medical drivers of health?
Well, thanks for this invitation. Thanks for my colleagues that have spoken, and to the name, you actually kind of got 80% on that one. It's Oluyemi, yeah, but it's okay. So the question about how do we measure social determinants of health? We can approach it from different angles, and of course, some of the discussions we've already had, or the presentations have touched on ways to measure that. But if we're trying to just come at it from a sort of structured, one way to structure how we measure would be to think about, because of what you just said, actually, which I really like, which is that non-medical, it's like you can call them non-medical courses. Other people have described them as such, the courses of the courses, right? So, especially if you come at it from a neighborhood level, which is what I do, so I'm kind of biased, you're thinking chemical stressors, right? So chemical stressors in the environment in which people live and non-chemical stressors, right? So that's one way to kind of look at it. That's not the only way. And to measure that, you first of all have to be able to characterize what we mean by neighborhood. Now, some may argue, and I think it's right, to think of social determinants of health also at the individual level, right? So you can think someone's personal income, their educational level, and so on and so forth. You can also look at even exposure to chemicals at the individual level. So if someone, within their living environment, being exposed to carbon monoxide, let's say. But the way I generally describe it, which is how I work, is that at the neighborhood level, what are the stressors in the neighborhood that are chemical, from chemical sources, and what are the stressors that are non-chemical sources? So you can think of a lot of the sort of socioeconomic, socio-demographic factors we've talked about, income, but being measured at the neighborhood level means you're looking at percent. So percent of people in the neighborhood that are X, or Y. And then, of course, the chemical stressors would be what quantity of PM 2.5 are we observing in this neighborhood, and so on and so forth. So I'll stop at that. I'm sure that as we move along, there may be opportunities to come back to sort of these types of conversations.
I want to throw something out, and this is a Houston story, and I can't remember if it's 4th Ward or 5th Ward, but there is a community there that's been affected by, and I think it's basically around the railroad, maybe the creosote and those type things. And could you speak to that? And especially, and this is all three panelists, what are the social determinants of health, in describing that area, and then what's the challenge there? But I can say I never thought I'd really live long enough to see any entity, and a government entity in particular, that would say this directly is causing cancer, because they've all skirted it. They never want to say that the power lines or any of the things that are affecting the people who live in those areas. And just because of cause and effect, right? If they caused it, then the effect is these people going to want some compensation for that, right? But anyway, let me hush and let you address that.
I can I'll jump in just quickly, and I'll jump in quickly to speak to this, that as you talked about that story that was on the news, and of course, like a lot of areas that are less desirable to live in, they typically are cheaper to live in those areas. Like, so usually patients that have lower incomes, they would live in an area that maybe is less desirable, from whether it's chemical plants or it's railroads or crime, all of the things that I kind of touched on briefly when I was going through the presentation. All of those things are real phenomena that occur. And just to throw a number out there for you, like when you look at non-Hispanic Black women in low-income neighborhoods, they were twice as likely to be diagnosed with triple-negative breast cancer compared to patients in high-income neighborhoods. So that neighborhood described on the news is that type of neighborhood. These consistencies, these numbers, these are real numbers. These are real things that are happening to patients in a negative way. And some of it has nothing to do with if they get to the cancer center where they are speaking with me and we give them their treatment. It's really related to their environment and where they live.
So speaking to Dr. Murray, when she's talking about Kashmir Gardens in the 5th Ward, of where, as we know in Houston, where our freight trains are, and this is not just Houston, by the way, but we've always maybe you've heard some variation on the expression about people talking about who lives on the other side of the tracks. And I'm doing, research right now related to rail and just saying, just actually trying to actually have empirical data to support, I think what we all have probably observed is that living near a railroad, let alone a railroad yard, is absolutely, an indicator of social and income status. I mean, for many reasons, people would not necessarily make that their first choice, but because of how having the rail yard go through, that it has decreases property values, which makes, that's where often what we might call affordable housing, but I hesitate to use that. I will call that low rent housing, because I like to think of affordable housing as being healthy housing, healthy homes that we've intentionally created in neighborhoods that have, where people have access to, kind of all the essentials, transportation, healthcare, food, schools, etc. But coming back, just using this example of the rails. So we already know like who is going to be experiencing any of the potential harms from rails are most likely going to be, again, our low income, Black, and, in Houston, Hispanic, but in most other cities and across the country, it would be predominantly Black. Then what are the problems from railroads that we're knowing? Well, this particular incident, it has to do with how and I'm not really an expert in wood processing, but how the railroad ties are processed and created, and they use the creosote to preserve it, and well, that's then leaching out into the soils and people are being exposed to it, even air and other pathways. And the big question is, what are public health officials, elected, appointed officials, and even the planning community doing about this? Where Dr. Murray said this is a big deal that this time in Houston, that this is one of the first times that people are saying, yes, we are acknowledging that this is causing cancer. And that's one of, I think, our big challenges in the research that we're doing, is that we need to get more of that empirical evidence out there so people can stop doubting and saying, well, how do you know it's caused by this? And, we're so caught up on that we don't move forward with what type of action has to be happening, because these people are experiencing the cancer, the other health disparities. Why do we have to prove it to move forward? Well, as we start getting more evidence, it just helps us move forward. So I just wanted to share that.
Yeah, I mean, if I may, I'm actually at an NIEHS conference in Baltimore, and we went on a tour of South Baltimore 2 days ago, and one of the places we visited was a coal processing plant from which coal is shipped out of the U.S. to India and internationally. And not only, as we've said, do they have the rail lines coming in with the rail, they actually have coal in the cars coming from wherever, uncovered. So they're concerned about the fact that the coal is uncovered, right? And the fact that the plant itself is not covered, right? You could just look at a heap, a large heap of coal being processed. And as everyone has acknowledged, it's usually, although I asked the question, what's the racial demographic sort of race ethnicity distribution? And they said it's like 30% white, almost like 30% white, Black, Hispanic. And the common thread is low income. So someone said, we went to other places that they used to live in South Baltimore 20 years ago. And the person was hearing the same concerns that were voiced when they lived in that same neighborhood about 20 years ago. And that was a response to a question about the need to do cumulative exposure assessment, right? Which is, science, saying, well, we need to do cumulative, which we all know we have to do. We need more evidence. But there's a reason why high income X, Black, white, Hispanic, they're not living there. They don't need cumulative health assessment, So there is And I'm in, I mean, like, I don't have an answer, but one of the things that come with these conversations we're having is, at what point are we able to move from knowledge to action? And what does that process look like? And I think that's a critical, fundamental, which is why I like the, earlier uh, presentation about voting. I didn't know it was going to have about voting in but, because, I think it's just important to think critically if we really want to solve the problems. I mean, if we can play around it or we can solve it, and how do we do it is a critical thing to figure out.
Yeah, voting is also a disparity. It's amazing, but it too is a disparity. And most of the people who opt out not to do it don't get the connection that this is how you get certain things done in your, where you live. It's all about where you live. So it's something that we probably need to add into this series, just do one on voting, really. So before we get too long in the hour, I would like both Dr. Hunter and Solitaire to each talk about their pilot projects that is also a part of this P20 funding that we're bringing this series to you from.
I'll let you go first, Dr. Solitaire.
Okay, thank you. So we do what we call Project 2, or the Bladder Cancer Project, in which our TSU side, which this has our urban planning team, myself and Jeffrey Lowe, involved with the rest of our TSU team and our Baylor College team, in which we are trying to get this evidence that I was referencing before that will, kind of supports what we know in the literature, the research of showing that, addressing the social determinants of health of bladder cancer and understanding the disparate impact that the disease has in, particularly in Black men. So while our Baylor counterparts are dealing with looking at tissue samples, and I barely can speak to that. I'll let somebody else speak to understanding how you at a cellular level are looking at what's happened with the disease. We're then following these same people as patients with a survey, asking them, it's called a life history survey, which primarily focuses on their residential history, where they live throughout their entire life. And with that information, what we are doing spatial analysis, using tools called geographic information systems, where we are taking the information that they give us, we're translating their addresses to points on a map in what we call census tracts. It's one of the many ways we measure neighborhoods, and have data from the U.S. Census Bureau on all the socioeconomic factors you could imagine, particularly race and income of the neighborhood. But then what we're doing is we're getting these other layers, map layers of data on environmental conditions. So what is there now? And ideally, because we're going back, looking what people historically, what data, what kind of land uses, what kind of facilities, polluting facilities, et cetera, may they have been exposed to over their life, to actually see if we see any patterns, and we can get the evidence that is kind of supporting the hypothesis that particularly the built environment aspect of the social determinants of health is correlated with their the nature of their cancer. So we are in the midst of working on this study, where we are about to the survey is about to go out to the patients of, again, asking them this this residential history. We also have questions about their work history, et cetera. Again, trying to see if we can come up with a methodology that clearly gives us evidence that we can use to further the work on social determinants of health as an avenue for health equity.
I would not be a good supporter of the funders who fund me if I didn't ask you. Are you aware of the All of Us database? And they have surveys in there for social determinants of health. for individuals that have participated or participating. It's ongoing, but there may be some use in there, and I think you are able to do maybe searches via zip code as well, but it's always nice control data, if nothing else. But the All of Us database at this point has over 800,000 participants, and there are thousands, because I wouldn't say it's 800,000 in terms of the social determinants surveys, but they ask most of those participants to answer these various surveys that they include. So just put that out there.
Thank you.
Welcome.
Thanks.
So I'll briefly, as I know the time is getting short, I'll briefly describe my project. It is a collaboration with Baylor College of Medicine as well. My co-lead on the project is Benny Caperatu, who works in the cell culture labs and cell biology, and also assesses like the efficacy of medications in the lab with in patients with certain types of mutations and problems. So on our project, it's multifaceted. The description is it's a biosocial project. So it has an aspect of social determinants of health that we would analyze. We also have a medication compliance component, as I am first before anything a pharmacist. And then finally, we have Dr. Caperatu and myself have been working prior to this grant together to analyze the resistance pathways of very prominent medications called CDK4/6 inhibitors in breast cancer. So we've identified several paths that are directly related to minority patients that may cause patients to not respond as well to the treatment. So that our project will analyze social determinants of health, looking at the Phoenix X or the Phoenix Toolkit. We'll have the All of Us databases actually involved in our translational research portion, where we are. We started actually with the All of Us database to identify some of these genetic abnormalities in patients who were on the CDK4/6 inhibitors who did not do well. And then I'll also be analyzing their compliance history with the medications, because you take these medications for a minimum 2 years, and some patients take them even longer than that, depending on the type of breast cancer that they have. It's metastatic versus if it's being treated adjuvantly after they've had surgery. So we're excited about the project. We already have several patients that have filled out the survey in the cancer center that I practice in. And the biological translational portion of it is underway as well.
All right. Both exciting projects. I want Dr. Ola Yumi to just give us a few minutes. Just tell us about some of the work that you're doing.
So as far as cancer goes, perhaps the one I would highlight right away is an attempt at trying to provide a platform within I'm a member of the Baylor Cancer Center, and I work with Dr. Rouse, and we've thought about a way to show both public facing and internal, just for the Cancer Center members, the burden of cancer in our catchment area. So that folks out there can actually go to like a one-stop, infrastructure where you can go, you can pick the cancer type, you can see what's happening where in the catchment area, and most useful for the Cancer Center members that want to plan clinical trials or say plan outreach events, right? So that same platform will allow them to say, okay, well, we see that breast cancer screening is lowest in this part of the catchment area. So let's target that area. So it's not research, but it's totally useful, and it helps others with their research as well. So that's just one example of the work we're doing.
Cool.
Thanks.
All right. Well, thank you. It was great to hear some of the work that you all are doing. I'm going to just ask everyone to give us a minute, maybe a minute. Yeah, because I checked. I don't see any questions in the Q&A or the chat. So, but wrap it up. What is it that you want community people to know about social determinants of health as it relates to how it's going to impact any particular cancer diagnosis?
Yeah, I would just end with, from my perspective, is just making sure that everyone understands how broad it is. Because I think that you get fixated maybe on one particular aspect when you talk about social determinants of health. But as you saw from the presentation, it's multifactorial. It's the environment, it's the access to healthcare. There's so many things that go into it. Just make sure patients understand that it's not just about like the type of care you're receiving. There's other things that could go into play as far as like how well you do and making sure you have the correct access and the voting. So I'll end with the voting. I've left the voting at the end for a purpose, because of course we have elections coming up, but I just think that the voting and understanding the candidates' positions on things that will directly affect you and your family from a healthcare perspective is important.
Well, I'll just say, someone gave a definition of, following up on what we said earlier, it's uh, non-medical factors that affect health. But then they said that can be influenced by social policies. So there is a solution to the problem. It's not lack of solution. I mean, there may be many solutions, but that can be affected or influenced by social policies that can impact health in powerful ways. So that latter half of that sort of thread of thinking, I think, would be important to convey to the community that it's not a lost cause. There's actually a way to get out of this, but it's going to take getting to that place. How do we do social policy change? And I mean, that connects to a lot of things, including governmental structures and all. So that's just one thought.
And I just want to share, while it's not, my comments are not about any one type of cancer, but looking at this as an urban planner, kind of just following up on Dr. Olami's comment, is we have means, there are avenues of how we can address these disparate impacts, but we have to acknowledge that there are disparate impacts. We have to know that while there's so many different policies out there that on their face are race neutral, that their impact absolutely is not, that they have this disproportionate impact, particularly on our Black and Brown and low income communities. And we need to realize that we have to start taking action on that and evaluating these policies and figuring out ways to improve, change, get rid of them, so that we can have significant health equity. Thank you.
Thank you. Thank each person who's provided their expertise today to help the community understand what we are talking about when we say social determinants of health. Because I always find that it's the examples, because most of the time, I think you're living it, but you're not thinking about how they may determine a good or a bad health outcome for you. And so these health inequities are killing us. They really are. Oh, next slide, Nikki. Because I think at least I see the code to scan, but in case somebody needs to still scan it.
Yeah.
Yeah. All right. And then I think we are able to do more than we know we can, but we just need to have each neighborhood, each community working together. They can solve problems. So I think that's something else I think the maybe Fifth Ward lesson is showing us too. So, real briefly, if you would advance to show the upcoming series that is offered by, and I forget the name of y'all's group, but anyway.
This is by
So
our
I'll let you do them.
Yes, thank you so much, Dr. Murray, for your great facilitation of today's event. Thank you, everyone, for hanging in there and staying with us and listening to such important matters. Dr. Rodney Hunter, thank you so much for the great presentation. Dr. Solitaire and Dr. Oluyomi, we appreciate you also for your attendance. Thank you all. Just a few recap items. Please join us at TSU on TSU grounds on Friday, October 18th for our third annual We Roar Against Breast Cancer We Roar Against Breast Cancer. It's lunch will be provided, and many clinical services as well will be provided. Now, to respect you all's time, I want to just update us about upcoming webinar seminars. Also on a Wednesday, taking place October 23rd of next month, is going to also run for 1 hour between 12 noon and 1 p.m. And this will be on the topic of community engagement and cancer. And sorry, it should not be community engagement, is it? Community engagement and cancer health disparity. And the last one for the year, I believe, would be Wednesday, also November 20th, and that would be on enrollment and retention for racial and ethnic minority in clinical research. And please keep it in mind that it's all on Zoom online, so you can eat lunch also and learn a thing or two. Thank you all for joining us. We really appreciate it. Also, next year, mark your calendars. Our maternal and child health education and outreach session taking place over a span of 4 hours on TSU ground, and our highly anticipated clinical research and engagement conference taking place all the way in April. But please go ahead and bookmark your calendars for this great and impactful events. Thank you so much.
Thank you.
This is a wrap. Thank you, everybody. Thank you, Dr. Murray, Dr. Hunter, Dr. Oluyomi, Dr. Solitaire. Really appreciate you all. And thank you to our AV and tech team, Constellation X, for great help with this.
Thank you. Bye.
Thank you.
Bye.
Bye-bye.